Good morning, good afternoon. I'm David Willis from the Nurture Connection Network and eager to welcome you to our Nurture Conversations. My dear friend and co-host Dana Long and I offer these conversations to advance Nurture Connection initiative and to really seek to advance early relational health for the support of strong, positive, and nurturing relationships and to build a healthier, resilient, and more connected communities. Hello, Dana.
Hello, everyone. It's so nice to be here with you.
So I so love these sessions during which I get a chance to introduce my most valued colleagues, our national thought leaders and friends, all who inspire me along this journey to advance early relational health and growing our Nurture Connection network. And today is really very special to me because of two longtime friends, Jennifer Tracey and Johanna Lister, for who I met when I was at HRSA over 8 years ago, I think, when we were just starting to look at how do we create sustainability, how does 0 to 3 and Healthy Steps create sustainability. And Johanna and Jennifer have been on this long journey, and I'm really excited to be able to talk for them to bring to you where that good work has come and the excitement we have about expanding the Healthy Steps model and also that team-based care model in even broader ways because it so advances a relational health frame. Let me tell you about each of them. Jen Tracey is the Senior Director of Growth and Sustainability at the Healthy Steps National Office. She leads efforts to identify financing strategies to support the expansion of Healthy Steps and to provide long-term sustainability to assist at those sites. And Jen works with key stakeholders to help shape state and federal policy to improve the coverage and reimbursement of these critical services. She's currently working with several state Medicaid agencies and Medicaid health plans for this effort. Prior to coming to 0 to 3, Jen was the Medicare Federal Policy Director for United Healthcare Community and State, where she influenced state and federal health policy. She also worked closely with state agencies to support overall Medicaid and CHIP program improvements and reform efforts. She also worked with Medicaid and CHIP Payment and Access Commission, where she focused on Medicaid care health policy issues and served as the quality lead to the Commission's Medicaid work. She has a Bachelor of Science in Public Health and a Master of Health Administration from University of North Carolina, Chapel Hill. It's like phenomenal, the background and the expertise, Jen, that you bring to this work. And similarly, Johanna Lister is the Director of Policy at Healthy Steps. There, she develops and implements strategies for advancing the Healthy Steps network on its implications of relevant policy changes for federal and state levels. She works at 0 to 3 Policy Center to advance the broader policy agendas. She's a member of the Healthy Steps National Office Policy and Finance team. She works with stakeholders, including providers, payers, and states, to promote favorable reimbursement policies to help deliver these critical services. Prior to coming to 0 to 3, Jo was a consultant with the Advisory Board Company. Her career has been largely centered around the intersection of Medicaid and children's systems, including the role Medicaid plays in child welfare, special ed, school-based health services, and juvenile justice. She has a Bachelor of Arts in Philosophy and Global Public Health and a Master's in Public Health from Washington University, and also a law degree, specialized in health law from University of Maryland, which is actually so cool. So welcome, my dear friends. And Dana, can I turn to you to kind of kick us off?
Absolutely. We are so fortunate to have Jennifer and Johanna here with us today. And just to remind the audience about the purpose of Nurture Connection. As you all know, Nurture Connection, it's a lively live stream series that is hosted by David and I to really explore with intentionality and in a thought-provoking way how we are advancing early relational health and to bring to light the innovators and the leaders within this space who are doing just groundbreaking work. And so we're so happy to have our guests here with us today. In order to kick us off, we would just love to know more about the both of you. Like, what is your personal journey to this space? And let's start with Jennifer and then go to Johanna.
Sure. Well, thank you for having us both here today. We were reflecting earlier how long we have all known each other and been working in this space. And I think it's wonderful as we were thinking about David Joe and I meeting with you in 2015, 2016, sitting in a conference room and thinking and really commiserating about the state of reimbursement for preventive dietetic services. We have come such a long way in 8 years. So I'm just super excited that Joe and I can be here to talk about that. My journey has mainly been in Medicaid the last 25 years. I have been in Medicaid some shape or form. It started when I was younger and saw my grandfather have to spin down to go into a nursing home to get long-term care. That was a really tough thing. It was a really hard system to navigate. And so when I went to college, I actually had a plan to become a nursing home administrator, and I had taken all the courses and just needed to do my internship. And then I figured that was a way to sort of have direct service delivery, help people like my grandfather and really work in long-term care. And at the last minute shifted to Medicaid policy, and have been in Medicaid policy ever since. David, as you mentioned, doing a ton of work with state Medicaid agencies in the 90s, helping implement Medicaid managed care. After that, helping states expand, pull in additional populations into managed care. Had the privilege to do a lot of work with Medicaid health plans over the years to figure out how could they better serve Medicaid beneficiaries that were enrolled in their health plans. And then, of course, had some great federal experience with the Medicaid and CHIP Payment and Access Commission. And then before coming to HealthySteps was with United Healthcare, which was really valuable because it let me in sort of on the plan side and get more insight into how payers make decisions on how they finance funds. So sort of pairing that with the state Medicaid agency lens, I think that experience has been really valuable at HealthySteps. I joined the national office in 2015, really for some personal reasons. I had severe postpartum depression with my first child and really struggled. And when I was speaking with 0 to 3 in HealthySteps about this opportunity, it was just an aha moment that hearing about the model, it really could have helped me so much on my journey as a new parent. A caregiver could have helped my family. And really that's what drives me, is the hope that, caregivers can get access to additional services that they may need so that they don't have to sort of go through challenges. Being a first-time parent or being a second-time, third-time parent, it's really a hard thing. And just knowing that you can go to your child's pediatrician or primary care setting and get some help for things that are going on with you, not only with your child, would have made a world of difference. So that's definitely what brought me to HealthySteps. It's what keeps me here. And, I think so many on our team have similar experiences like that. So thanks for letting me be here today.
That's great. And Joe, how about you? What's your journey? How did you get here? And what kind of
Thank you, Jen, for answering. Joe.
Yes, thank you. Well, I echo Jen's appreciation for being here. It's really nice to have this conversation with longtime friends and allies and colleagues. I was talking to my 6-year-old this morning about what I was doing today, and he was marveling at the fact that I have known both of you longer than he's been alive. That was mind-blowing to him. So as David said, my background has always been in children's health policy. It's really where I've been passionate and specifically focusing on Medicaid. I was a policy baby when I was getting my MPH under Sarah Rosenbaum, and that really shaped the focus of my work in many ways. I think working in DC was really an opportunity to understand the ways in which Medicaid really interfaces with so many different aspects of children's lives and really explore that. I then went to law school because I love to learn, and I was surrounded by a lot of lawyers. I was in DC, obviously, but really helped me understand some of the ways to influence Medicaid and to understand it better and to push it further. So that was a really exciting piece of my career. I don't have as good or as profound a story as Jen. I think I've just always felt like children need as much of a voice as they can possibly get. I felt that before I had children. I feel it even more strongly now. And I think, I hadn't really worked in the early childhood space as much. I had done some work with Part C, but it wasn't until I came to 0 to 3 that I really got that understanding of the early relational health frame, of that piece of it, of, really embodying the phrase that we echo all the time, which is babies don't go to the doctors by themselves. And so and their families.
That's phenomenal. So I hope you can all hear me. We're having a little bit of in and out with the internet. I think we'll be playing with that through this session. But I wonder if one of you could, who wants to tell us about Healthy Steps? Many in the audience may not know about the Healthy Steps model. I wonder if one of you might discuss that a bit before we get deeper into how it relates to nurturing and especially what's really exciting on the policy space.
Sure. I will take that, Joe, if you don't mind. I will do the super quick version for those who aren't familiar. Healthy Steps is an evidence-based model. It's interdisciplinary, resides within the pediatric primary care setting, and it really focuses on promoting nurturing parenting and healthy development for babies and toddlers. So really children ages birth through age 3 and their caregivers. And the model centers around a Healthy Steps specialist who is integrated into that pediatric care team to provide short-term behavioral development consultations, referrals for services that may be needed by that family, more intensive services when needed, and then also to support practice-wide screening efforts. And there are 8 core components of Healthy Steps that every site, every Healthy Steps site across the country must provide in order to call themselves Healthy Steps. And those 8 core components are child developmental, social, emotional, and behavioral screenings, screenings for family needs, a family support line that allows caregivers and the family to reach the Healthy Steps specialist with developmental questions, child development and behavioral consults, care coordination and systems navigation, because we know sometimes families require assistance outside of the practice. That may come with referrals, and we want to make sure that those referrals stick for those families. Positive parenting guidance and information, early learning resources, and then also ongoing preventive team-based well-child visits. And we like to think about those core components really organized into 3 tiers of service delivery. We think of tier 1 as universal services that all children birth through age 3 and their families in a practice receive. And those services are the child screenings that I mentioned, the family screenings, and access to that universal family support line. Tier 2 is where we see families maybe needing additional intensive supports on a short-term basis for maybe mild concerns. And these services include child development, behavior consults that I mentioned, some of that care coordination, systems navigation for those referrals, positive parenting, and early learning resources. And then finally, for the families that have the most intensive needs in a practice, we think about those individuals and those families as receiving tier 3 services. And that includes all services in tiers 1 and 2, in addition to providing those ongoing preventive team-based well-child visits within those first 3 years of life. And that's really where the Healthy Steps specialist is co-managing that well-child visit with the provider in conjunction with the family. So that is a brief overview. If there are any questions, that we'll be glad to entertain those.
I'll make a quick comment, and then Dana, you certainly recently Kay Johnson and Charlie Bruner started calling this the high-performing medical home to make it very clear that it's a transformational model for prevention and promotion. That's team-based care, best evidence-based practices, a coordinated process of relationship building, and then coordinating with communities. It's really absolutely phenomenal. I did miss what's the breadth of the number of sites you have, how many states you're in, that kind of spread. And then Dana, I'll turn to you for your reflections.
Yes, absolutely. We are in over 230 sites across the country now, in over 25 states, and also in DC, and growing every day. Lots of upcoming interest, and I think, that's due in part to providers and others just embracing the team-based concept, integrated care, but also because there are so many exciting sustainability pathways that states are opening up, and even on the federal government side, that are really allowing providers and practices to embrace these types of evidence-based models to really better serve children and families where we know they are, where they seek care.
So thank you for that clarification. I have a question just about like the scale and sustainability of your spread, because it is such an amazing program. Can you walk us through the history of where Healthy Steps started and what your sustainability strategy and your scale strategy has been?
Sure, Joe, I can take a first cut, and then if you want to jump in. Healthy Steps has been around since the 1990s, and it's a model that came out of Boston Children's with funding and support by Robert Wood Johnson, and actually in collaboration with 0 to 3, placing a childhood development specialist into the pediatric setting with the realization that there were so many things going on with providers that were happening outside of the clinic walls that they couldn't always manage in a visit. And so having a child development specialist there to answer questions that maybe a pediatrician didn't have time to address, or maybe didn't get the medical training around child development, and even more so handling concerns that fall outside of the clinic walls. We talk so much about social determinants of health and the impact that they have on families. So the first initial 8 sites were started up in the 90s. In the early 2000s, as the number of sites started to grow, there was initial randomized control trial that showed some really promising results across a wide array of areas around Healthy Steps supporting early learning, well-child visit, timeliness, immunization, some really strong support. After that point, Healthy Steps continued to grow through the 2000s under the leadership of several entities and individuals. I will call out Margot Kaplan-Sanoff, who we attribute as one of the initial founders of Healthy Steps. And she kept the program going and running and did a wonderful job. And she finally, I think it was in 2014, decided that she wanted to retire and pursue other things in her personal life. And so she approached 0 to 3 about bringing Healthy Steps back to the national office, back to the entity. And then in 2015, there was an investment by Blue Meridian Partners in Healthy Steps that allowed the establishment of a formal national office that had never existed before, to really focus on codifying the model, getting a handle on how many sites were in the network, focusing on sustainability. And we often say that at that time, there was a real recognition, it felt like, of payers and Medicaid of the importance of young children that has continued to build, but wasn't necessarily there in the mid-90s and in the early 2000s. So we always say Healthy Steps, we feel like, is a model whose time has finally come. And I'd say over the last 12 to 18 months, we've seen some really exciting things. Joe, anything else you would add to that?
So one quick correction, which is that I think it was Commonwealth funding. So in case any funders are watching.
Oh, thank you. Thank you.
The initial Healthy Steps sites. The only thing that I would add is that I think when the national office was really established at 0 to 3, we put a lot of thought into, of course, the sustainability question, but also how to scale. And while that is still very much a question and a dynamic, I think what was surprising to me, at least, is that demand was never an issue. We did not have to market it. We did not have to shout it from the rooftops. Providers and communities really want Healthy Steps and models like Healthy Steps. So I think that was very telling in terms of really launching the journey in 2015, 2016, that it was not something we had to sell. And I think we were delighted to know that because we felt so strongly in the benefits. But I think that was interesting and surprising to me, that it was just sort of, we need to figure out, where this fits best in terms of communities' needs, and we need to figure out sustainable pathways. But that the demand was there and that families and providers really want it.
Johanna, that's such a strong point. Being an old developmental behavioral pediatrician, right? There's been a long sought after desire to strengthen promotion, developmental services, now relational services within the medical home for all. Mm-hmm. And Healthy Steps has always been in that space, well accepted by families, well valued by the pediatricians that ventured to do so, but there was no sustainability plan. Mm-hmm. So doing. I think there was a little history of McVie playing a role for a brief period of time. And then there were policy changes and the like that created the opportunity that now has really just expansive. But you're exactly right. What's been known about expanding a team-based care model with evidence, but also partnership and the whole promotion strategy and the tiering of promotion is now screaming and ever more evident as we need to really look at building well-being of families and children from all the drivers that we know, not the least of which are relational, and then all the social determinant vulnerabilities. Dana, what are your thoughts and reactions too?
I would love for you to be able to walk us and the audience through.
You're breaking up, Dana. I assume you were
I believe in the value of early relational health.
Yeah.
Mm-hmm. I was asking just to walk us through the process of how would a clinic go about establishing a HealthySteps site?
Joe, I'll be glad to. Do you want to take that one, or do you want me to? I think we have a delay, so I'll start off. Typically, as Joe mentioned, we never have trouble with demand. And so oftentimes we have practices who have heard about HealthySteps, and or they have a physician who had HealthySteps at a previous medical practice and says, I can't practice without HealthySteps. We need to bring it into our practice. And so they approach our national office, and we have an onboarding and exploratory process where we provide just a whole host of resources and information to communicate the core components of the model, talk about qualifications, ideal qualifications of a HealthySteps specialist, what it means to be a HealthySteps site, our fidelity metrics at the national office. What are the requirements? What do you have to meet in terms of quality? We also have reporting requirements at the national office to ensure that our sites are at fidelity and reaching fidelity in the timeframes that we anticipate. We also talk to them about sustainability options within their state and think about how can they fund their programs. We have a lot of states that initially approach us maybe with grant funding for an initial year or two. We know that's wonderful for implementation. It will not sustain in the long term. And so we do a lot of work within our national office to think about how we could fund those sites through Medicaid, other publicly available resources so that they can secure long-term funding, maybe sometimes when those short-term funding sources have run out. The other piece that since COVID has been really fascinating to see how we've made the pivot. We used to hold our HealthySteps Institute training. So we would do all of this wonderful onboarding support and then go on site and train sites. And with COVID, we really had to shift how we were going in and training sites. And so now we've moved all of our practice trainings online into a virtual environment. So now we have what's called a virtual HealthySteps Institute. So not only do we provide all of these upfront implementation supports, when we try to level set with sites, figure out where are they on providing universal screenings, where would they need to expand what they're screening for another in order to meet HealthySteps fidelity, how do they have to think about changing practice workflows. The other big piece that we've added in has been around the EHR and data collection, because for so many of us who understand the abysmal state of pediatric EHRs, they haven't collected Bright Futures information in a standardized way. And so if we have time, we can talk about the exciting things we've done around that at the national office. But basically all that wonderful onboarding support leads up to a virtual HealthySteps Institute where everyone in the practice gets trained, because as David mentioned, it is practice transformation. And on the back end, there are technical assistance calls with our national office and ongoing supports that we provide. So it really is a comprehensive practice transformation process that we undertake with really everyone within the practice. And the last thing that I will just add, Dina, that sometimes there can be a confusion about is the sites themselves actually hire the HealthySteps specialist, not the national office. So we work with them to figure out who's really the right person and the right fit to be the HealthySteps specialist.
I wonder if
Jen,
you'd like
David,
to talk
Danya.
about the financing journey, the sustainability journey, and where the current status is of what you've learned, and how both consistently across states and then individually across states, what are you learning about sustainability and advancement of the model?
Sure. I can take the state piece, and then Joe would love for you to weigh in on the federal side. I think for the first time, we are seeing our healthcare system beginning to pay for behavioral health prevention services, and more specifically, we're seeing state Medicaid agencies that are opening up new sustainability pathways related to preventive dyadic services for young children and families. And really not waiting for a behavioral health diagnosis to reimburse for services. We're also seeing a lot of those pathways support integrated team-based care for the first time ever and making some great strides towards workforce equity. So allowing reimbursement for non-licensed staff, including community health workers, which is really exciting. We're also seeing states replicate. So where there are successes and sustainability wins, we're seeing other states adopt those. So they're not having to reinvent the wheel, which has been great. It's okay. I'll just share sort of 3 big wins that we're seeing sort of hopefully influencing other states. And one of the first that popped up earlier this year that's been in the works for a while is in California. And California has been one of the most innovative states. And in January of this year, the state Medicaid agency launched a whole new set of first-time ever dyadic benefits that were modeled after HealthySteps, but the wonderful thing is those can be leveraged by providers, an array of providers who are delivering preventive dyadic services for children anywhere from ages birth to 20. And some of those new dyadic benefits are things such as dyadic behavioral health well child visits, which don't just focus on the child, but focus on the child and the caregiver and thinking about family needs and really advancing mental health parity. We're also seeing California now paying for things like community support services. So paying for the time that it takes a provider to ensure that a referral sticks, and that's a referral for medical, social, educational services that our health system typically is not reimbursed for before. Things like dyadic psychoeducational services and dyadic family training, counseling for child development, and also really exciting preventive psychotherapy services. So allowing therapy services based on psychosocial circumstances as medical necessity rather than a behavioral health diagnosis. So California really led the way with that. And since that time, we've seen Massachusetts and New York, those state Medicaid agencies also adopt what California has done. And then finally, we've seen California do some really exciting things around dyadic caregiver services and ensuring and expanding beyond depression screenings that can be billed under a child's Medicaid ID number, allowing services like emotional behavioral health assessments for caregivers to be provided during a child's visit and be billed under the child's Medicaid ID number. A couple others, if we have time. Maryland Medicaid just recently in January of this year opened up an enhanced payment of $15 for all well and sick child visits to be paid to HealthySteps sites across the state. And those payments are good for all children in a practice birth through age 3, regardless of whether or not a HealthySteps specialist participates in that visit. And the payments are really based on the fact that HealthySteps is a universal program. All children, regardless of whether it's a well child or sick visit, could have access to that specialist if their needs arise. And those payments are based on a HealthySteps site being on track or meeting HealthySteps fidelity requirements. And so our national office is able to attest to that annually, and then those providers can draw down those payments. The other really important piece is that the Maryland Medicaid payments to these sites do not rely on the licensure of the HealthySteps specialist. So really promoting workforce equity and allowing sites to determine the most appropriate staffing that really meets their needs. So those are just a couple examples that we're really seeing, and I'll just share Arkansas. actually modeled after Maryland recently and just passed some groundbreaking state legislation that will enable similar enhanced Medicaid payments, modeled again after Maryland for well child visits. So instead of naming HealthySteps, those payments are going to be based on pediatric team-based primary care evidence-based models within medical homes. So the legislation does not specify the payment amount yet. That's being worked out through the state Medicaid agency. The payments are model agnostic, but still a wonderful example of how a state looked towards another state and then modeled some innovative payments around that. So I'll pause there because I know Joe also probably has some exciting things to share on the federal side as well.
Jen, I can't write fast enough. It's like amazing. It's so well done. It's so amazing.
We have a whole team that's been supporting all of these efforts. So it's super exciting.
Well, my sincere apologies. Of course, my internet does something wrong the one time that I'm doing anything live. So I apologize, but I'm here and I'm on my phone.
Great.
Well, I'm so glad that Jen got a chance to share some of those. I think a couple of things. So one piece that I want to raise is that I think there's such a parallel process in terms of the work that it takes to advance policy and these sustainability efforts and the work that actually goes on within the primary care setting. We talk about all of this as relationship based, right? And I think that's something that we all agree on very foundationally. And I think about the relationship between the child and their caregiver and their community and the providers. I really think a lot of what's been able to help us advance the sustainability work is the relationships that we are developing and maintaining, both in terms of our colleagues, other people who are doing this similar work and share this space with us, and in terms of the relationships that we're making with policymakers. I mean, we talk about some of this work as if it, I know we don't actually mean this, but we sort of talk about it like this just happened. And I think it's so critical to remember that this happened because of years of developing relationships, educating people, really, for me on the federal side, really watching the brain science be fully accepted. So I think there are just all of these aspects that take time and take perseverance. And I think that's just an important lesson in all policy, especially in this country. So I just share that because I do think that that is foundational to these successes. And I think the longer we toil away at it, while it may be frustrating, the more consensus and the more people we have sort of echoing these messages. So while the time it takes to achieve policy advancements can be very frustrating, I think it's really amazing what we can do collectively as part of that journey. So I just
Joe,
that.
Joe, thank you for sharing that. And I do wonder, just like Jen had mentioned these advances in California, Arkansas, Maryland, can you give us some more insight into what the advances have been on a federal level in order to support HealthySteps and even more broadly early relational health?
Yes, absolutely. And when we talk about advancing HealthySteps, we sort of use that as a catch-all, but we really mean, the high-functioning medical home, HealthySteps and aligned services. So just want to make sure we're talking about it more globally. We have had some really exciting progress. I think, David, we have to credit you with, laying some of the foundation when you were at HRSA. But HRSA in particular has been really moving towards this idea of bringing in early childhood development expertise into primary care. I think we all know the role that primary care can play, and I think I'll actually say the role that primary care needs to play. And I think that there is now much more of an understanding about how to operationalize that. So, the AAP has always had bright futures. It's not new, but what is new is the ability to try to put that into practice and then to support that. And so on the federal level, within HRSA, we've seen both the Maternal and Child Health Bureau and the Bureau of Primary Healthcare, which oversees the health center program, really embrace the idea of bringing in early childhood development expertise and funding it. And so what we're seeing on the Maternal and Child Health Bureau side is an effort to much more deliberately bring the medical home into the broader systems building work. I think MCHB has always been really pioneering in terms of early childhood systems and understanding the role that they need to play in communities and states. And I think more recently with TPEC and with other transforming primary care for early childhood, sorry, TPEC, the acronyms, really embracing the idea of how do we build the infrastructure to support this kind of medical home. So not just about placing the developmental expertise within primary care, but really how do we support that? How do we create an environment where that can be sustainable? How do we create communities where there's buy-in across the board? And so that's been really exciting. And 0 to 3 is home to the TA Center for that work and some other work that MCHB has been doing. But 0 to 3 has also been very instrumental in the policy work, sort of pushing that forward and helping to get congressional appropriations to fund that. On the health center side, we're seeing sort of a parallel, a little bit of a bigger scale, but less on the infrastructure building side and more on the direct service delivery. So a large investment from BPHC to fund 150 health centers to incorporate early childhood development expertise. And so those, we should know pretty soon, those health centers that are going to be awarded. But it's another really great example of executive branch agencies just kind of getting it and funding it. And I think that's always one of many challenges within the policy space is there's the programmatic aspect and then there's the funding aspect. And I think we're at a really unique point where both of those are aligning. I have said this 1,000 times, but I love in a conversation with Jim McCrae, who oversees the BPHC, he said something to the effect of, I've heard more about child development in the last 6 months than in the last 6 years. And that just tells me, what we're doing is working. And, community health centers are at the forefront of so much work in healthcare and beyond healthcare. And so I think it's really exciting to see that historic investment really taking place in health centers. And that's a $30 million investment that Congress has made. And in the president's FY24 budget, he called for an additional $55 million for that. So time will tell. We know how all of that can play out in appropriations processes, but there's a real groundswell around the importance of this and understanding what we can do for children and families if we start early. So I could go on about the federal work. The only thing that I'll add that I think is both really beneficial in terms of the structure of both our national office and of sort of collectively the stakeholders that are engaged in this work is that there is a lot of this bi-directional learning between state and Fed. So none of this happens in isolation. And most of the advancements that Jen has been talking about are within Medicaid. And so, on the federal side, we have the beautiful task of elevating those examples of how states are doing this well, and then talking to CMS about what can you do to really facilitate states feeling empowered to make these changes. So I think that's another piece of this is really trying to attack it from all angles, share the really exciting work that is happening, push where we need to push, which is generally everywhere in my view, but that's just part of the role. So I think that's just a really great position to be in when we can both share the wins that are happening while at the same time saying, let's keep going.
Joe, that's absolutely phenomenal. And look at the progress. It starts with vision and then holding the vision in mind and then opening every door one can. Linking community and the medical home in very intentionally then supported ways with fidelity and purpose. Two things jump out in my own thinking. One is now that that's happening, how do we think about equity and trusted partnership with families and anti-racist structures and on one hand. Secondly, how are you all thinking about longitudinal data to demonstrate that all of these models actually make well-being outcome improvements at a population or community level? How are you thinking about those two elements?
Yeah. Well, I will speak to the first. I I think the data question is so important, and I will not pretend to be able to speak eloquently about it, but can share a few things that our national office is trying to do. I think to your first question, David, I think it's so essential. Part of why I am so excited about the community health center piece of this is that community health centers by design have community engagement. There is a patient on the board of every community health center. And so I think that structure and the fact that that structure is well established really helps bring in these new programs, these service expansions in a way that can resonate with the community. And I think that's one of the beautiful things about them. And I think that's something that's really different and partly why it's scalable in community health centers. Communities vary greatly, as we all know, but the fact that there is a community member that is a part of decision making for every health center, I think that cannot be overstated how important that is. So I think that's one piece of it. The equity piece, I think, is something that, you know, we all think about. One way that we are trying to think about it in the national office perspective is around workforce and really being able to elevate lived experience and not solely relying on licensed behavioral health professionals who have had the opportunity to seek higher degrees. And so part of what we're trying to do around that, I will not say we've done, but us and many others, is really trying to design these sustainability pathways in a way that leaves room for, again, whoever the community thinks is the right person to be delivering these services. So we talked about the Maryland example. That's really around practice transformation, not around the specific person that you bring in. Same with the community health center opportunity through BPHC. It's really about how can you increase certain developmental screenings and referrals. And it's not about how can you bring in a PhD. And so I think that's an important piece of all of this, that we really leverage the true expertise that exists in communities and not have this sort of top-down approach. The other piece I'll just mention quickly is that the national office has developed core competencies that are publicly available because we really fully believe in this around how do you deliver these types of services? What does it look like to be in a well child visit at 2 days, at 2 months? And the purpose behind this is, again, to make sure that we feel like we're doing our due diligence, that people who are implementing HealthySteps are delivering quality services, but not saying who those people are. And I think that is a really essential piece of both tackling workforce challenges and really looking at this through an equity lens and looking at, you know, if a family comes into a clinic, who do they want to talk to? Who do they trust? Because if they don't trust that person, that HealthySteps specialist, it's kind of for naught. So really trying to think about it from the family perspective. Jen, I don't know, I've left you the data question, which is a doozy, but feel free to add to anything I said, and we can certainly
that's okay.
share some thoughts from the national office. But sorry, Jen, go ahead.
No, I think it's interesting on the equity piece. I mean, we at the national office try to have a very intentional goal of serving and expanding in a variety of states. And, you know, it's fascinating to see the examples of the great things that are going on in California, the great things that are going on in Maryland, and the exciting things that are going on in Arkansas. And so we do try to work across a variety of states, because we want to be able to lift all children and all families up, and our sustainability work is so important. So we really focus on where are we going to intentionally grow our footprint, where are we also trying to open up policy levers. So that is a piece that we take very seriously and we think about. On the workforce equity piece, it's interesting because we are seeing progress in states like California, where states are opening up exciting new codes. And a lot of times those codes are for licensed professionals, which, you know, give or take, it's progress and it's wonderful. On the opposite end, we are seeing states like California and New York is in discussions now where they're going to be opening up community health worker benefits, which is wonderful. The piece that we often think about too is there's a spectrum in the middle as well. Individuals with maybe master's degrees who aren't practicing clinicians and maybe who don't have their licensure, but have, as Joe mentioned, wonderful lived experience, wonderful education experience. So how do we create opportunities on the sustainability spectrum for all of those individuals that play a role in team-based care and integrated care? Because again, as we continue to face workforce shortages, I think we're going to have to continue to get creative with our state partners around thinking about getting out of the way that we traditionally have always credentialed Medicaid providers and other providers, and really thinking about lived experience in a very different way across individuals with master's degrees, bachelor's degrees, associate's degrees, and others who have real lived experience in the community and who can add a real benefit and value to individuals that they're serving within a medical setting. So I think that's something that we all need to get better at. Payers need to get better at, and it's something that we are trying to tackle and we're thinking a lot about.
One thing I just want to add quickly, and I may be becoming a broken record here, but I think the benefit of sitting within 0 to 3 as a larger organization is you get to see all of the policies that really touch children and families and their caregivers. We have to address poverty. I feel so stressed. And David, you're probably smiling because I, with the microphone said this in front of a lot of people recently, but I think fundamental to all of this work, I really believe, is getting the child tax credit permanent. I think we don't necessarily think about it as a piece of the healthcare puzzle, but it is so foundational to everything that we are trying to do for children. No child should be born into poverty anywhere, but particularly in this country. So I just add that because I think no matter how focused we are on sustainability for specific services, which is absolutely crucial, I just think there's this foundational piece that I don't want any of us to ever forget about.
Joe, Dana, and I are right with you, 100% times 10 times 10. And that sense of the continuum of sustainable relational health workforce, like who are the relationships that one can use to build healing narrative and well-being.
Absolutely.
Once the child tax credit passes, then we have to heal the culture from all the trauma that's so deeply embedded forever in this culture around separation and isolation. That true liberation movement has to be embedded in a relational frame. So thinking about, from a health sector view, that continuum of the relational health workforce who bring narrative for healing, deep connection, shift the power base of partnering with families and communities for their well-being, and the health system playing a platform role as well as an assurance role gets to be is right in front of us. Our view is a team-based care models, the HealthySteps model is right there and helping shape and lead those opportunities forward as we're really trying to heal our nation or respond to the Surgeon General's call for connection and the sense of really finding well-being from the very start, this relational health movement, and from all we know in these activities. So I'll personally say thank you for the power of what you've all been doing, by the commitment to a vision that you've been holding tightly, and then relationship by relationship by relationship, state level, leadership level, federal level, to really operationalize these opportunities is truly phenomenal as a movement.
Well, thank you back, David, because you have been a partner to us in all of this. And if it were not for pediatricians like you and Dana, this would be a very different conversation. So we are grateful for the partnership as always.
Well, Dana keeps us grounded in real life practice because she lives day in and day out, right, Dana?
I do, and based upon that, I have a question. And David, when you asked Joe about equity and anti-racism, and understanding that this work is so important in community health centers, how are community health centers funding that identified community member who will become the HealthySteps specialist in a way that is going to be providing sustainable services to clinics?
Well, it is a work in progress, like all things. The way that the funding currently stands, it's a 2-year grant for whoever assuming BPHC grants the funds to whoever has applied, they will choose who should be that early childhood development expert. What we are doing on the policy side is working really hard to make sure that there is a path beyond those 2 years. So whether that path is a stopgap measure of 2 more years, maybe, but what we're really hoping to do is to build it into the base rate for community health centers. Health centers are paid under a different structure, and they have 330 grants from HRSA. So what we're hoping to do is create a really sustainable pathway by making it by continuing with what's called essentially a service expansion grant. So building it in so that this becomes part of the operating budget of a health center. I think this, I don't want to speak for you, Jen, but I do feel like this in many ways is our broadest mission, in that we just want team-based care to be the standard of care. And I'm hopeful that the way that we can do this for now, or at least in the next 5 years, can be through the infrastructure of the health center program. I think not only is it important because of as I was saying, the structure of the board and the ways that they have always done community engagement, but because they're everywhere. I think from a policy perspective, it's really exciting to have something that is relatively nonpartisan to be able to shout from the rooftops. I mean, every congressional district has a health center. And so I think, again, from a policy perspective, that makes us a little bit more optimistic that we can create a more sustainable funding stream within this setting. Again, I say this, I've been in policy long enough not to be particularly optimistic ever, but I do think community health centers are such a special safety net infrastructure in this country that I'm excited about the possibility of really creating sustainable funding there, and then having that sort of be proof of concept. David, you asked about the data piece, which Jen and I skirted because it's not our expertise. But I do think the more entities, the more practices, the more communities we have that are implementing team-based care, the more we'll know what works and what doesn't. And I do think part of the beauty of HealthySteps and similar models is that flexibility for communities to respond to their own needs. So I'm really hopeful that the health center piece can be sustainable, can be long-term, and can be a backbone while we sort of fight this fight in other corners and in other ways. But time will tell.
Yeah, and apologies, we couldn't make a nice pivot to the data piece, but glad to chat about that for a minute or two, because I mentioned earlier, I think, we've done some really exciting things at the national office that we're hoping to spread. So we have a minute. I just love to share about some of that, David. And I know, Dana, as long as you're okay with that, I can try to be quick. We had talked about earlier just sort of the mess that electronic health records can be, especially on the pediatric side. And so our national office had a massive win in this area. And this last winter, we released what we call an Epic EHR playbook to our HealthySteps network. And we just held a demo last month. That was a webinar with some of the staff at Epic National, our production partners at Nordic, and then with one of our pilot sites for the EHR playbook, Riverside University Health System out in California. And EHR pediatric modules traditionally have not been set up to capture dyadic family-based care work. They don't really allow for documentation of features of a HealthySteps visit. And if health systems really want to track and document all of the great things that they're doing under HealthySteps, they really have to start from scratch and try to build something themselves, which isn't always practical. It, of course, can lead to very inconsistent data. It's hard to analyze. There isn't any standardization to it. It's hard to extract. And then trying to get pediatrics lifted to the top of an EHR build is almost never easy. Pediatrics is never really at the front of those EHR customizations within health systems. So our playbook that we released is now just for Epic, but pending more funding, we're going to try to expand that. But with the playbook, sites that use Epic and download the playbook, there can be standardized data, no more double documentation for some who try to record things maybe separately outside of the EHR to manage their workflows. It can increase productivity. There's no more free text, so you can better query, no more hunting and pecking, and then also a way to better track patient care plans, referrals, all the things that we know make a difference for families and making sure that they receive services that typical EHRs can't do off the shelf. So it's a really big deal. We've heard from Nordic that it's really the first example ever of a pediatric improvement model being integrated into Epic. And later this summer, just as super exciting, we're going to see national dissemination via a turbocharger package of the Epic Playbook. So basically equivalent to an app store where any health system, any provider, not just HealthySteps sites that use Epic can actually download the HealthySteps playbook just by clicking a button. HealthySteps is aligned with Bright Futures, which is the American Academy of Pediatrics standard of care for pediatrics. So it will allow systems to document all features of a Bright Futures visit. So as Joe mentioned, getting beyond HealthySteps, just going to accepted pediatric care and what we know practices should be doing. So even if they aren't doing HealthySteps, they can still leverage that. So I think we're all thrilled about this new technology solution. I think it's going to help a lot in transforming the promise of pediatric care. But more to your question, Dana, around trying to help with data collection and trying to sort of get our arms around what is, standardized data collection look like for team-based integrated care. This is going to go a long way. So starting with Epic and then hopefully expanding that as more funding allows.
And I should just add that I will say I started the question because Jen, of course, just answered eloquently, but we do have a robust and amazing data and evaluation team at the HealthySteps National Office that is thinking about all of this. I know part of what we're working towards under the leadership of Jess Bouchard is trying to support sites doing their own research as well. So again, when we talk about sort of how it looks in particular communities, trying to support that work. So there are brilliant people at the national office who are thinking very hard about this and doing really great work around the evaluation and data collection piece. I'm just not one of them.
Well, it's so amazingly good. I mean, what Epic touches, was it 30 to 40% of practices? It's a large platform. I don't have that number exactly right.
And more, for our network at least, I think it's about a little less than half of sites, but more than half of children.
Right. It's a huge lever of practice delivery. But I'm going to push a little bit. I was also asking about well-being longitudinal data, because the early relational health movement, the team-based care movement, the early childhood development practice transformation still has to demonstrate demonstrations of improved well-being. And that, of course, we know the drivers that disrupt it: poverty, trauma, isolation, maternal well-being, blah, blah, blah. We go down that list. But as we get stronger in supporting families and communities, and as we get breakthroughs in, certainly poverty reduction, anti-poverty movement, and the like, we still have to show that we can demonstrate improved social emotional well-being by a relational frame and a healing frame. And everything you've been setting up will allow us to begin to look at well-being indicators, maintaining developmental well-being on track, keeping a developmental screening tool on track, seeing a mother improve in her stress level to well-being, decreasing maternal depression towards a greater sense of thriving. These kind of monitoring systems are coming in too, so that we can actually show to those that go far beyond health system to say, are you really making a difference with all we're investing into the future of our children? How do I know that our children in our community are being stronger? And we're starting to see glimmers in the place-based work in Bridgeport, Connecticut. I know that the population-based work that's going on in the Carolinas are trying to look at this same longitudinality of well-being, and HealthySteps is right in the center. And now the data platforms and now the policy platforms to really start demonstrating those kind of moves. I went off on a tangent because you can sense how excited I am about this work. And to all of you listening in from our Nurture Connection networks, pay close attention here. Elevate what we're hearing over this last hour to all people in the policy space and in that link between medical home community and equity, because there's a movement building, and these dear people at HealthySteps with their vision far bigger than our model, far towards a transformational view of the health system's role with communities partnering with families is really a transformative moment in time. So any final thoughts? Dana, your final thoughts, then Joe, and then Jen, and then we'll finish up. I think Dana's got
My final thoughts are thank you to Jen and Joe for joining us. And I would love to have a vision where these services are covered within community health centers across the country. And so I can't wait till we get there.
Well, my final thoughts are just gratitude for this opportunity, for the partnership. This is, this work is Sisyphusian in many ways, but the more people we have pushing that boulder, it's just really amazing to see what we can accomplish together and moving towards that vision. So thank you.
Yeah, I would echo Joe's thanks and just the importance that we found of local voices and local partners in this work. All of the states that we've highlighted today, we've worked with entities on the ground to help advance these policies, and we wouldn't have gotten this far without them. And so I think as we talked about, the relationships matter. It takes time, and we are seeing movement, and that's super hopeful. I think we see wonderful signs that it's going to be a domino effect, more and more states, and we'll just continue to work with you all and local stakeholders to really advance some of these policies, because that's where the work gets done, and that's where we can make real change. So very excited to be here today.
Phenomenal. So the Nurture Connection movement is a social networking of a network of networks, a community of communities that are holding this vision of transformation and change. And your partnership means so much to us. Thank you. And to the audience, thanks for joining us. Later this month, we're going to be having a special session of our Nurture Connection where we have a chance to have a conversation with CSSP's new president, Leonard Burton. So please join us on June 28th. To be continued, thanks all. Be well. Happy summer. Bye-bye.